This is the final presentation for Unit 6. This is Part 4. Let's practice applying our knowledge to results obtained. What I'd really like for you to do is when you get to the slide, pause it, try to figure it out yourself, and then hear the explanation. And do this for each case study. Pause the slide and work through this discrepancy for a few minutes. Good. I'm hoping you came up with the same answers I did. So what is the problem? We have a 3+ with anti-A, so the patient's group A, a little bit weak, should be 4+. And then we have anti-B, which is negative. So the patient, if we look at it, they have forward typed as a group A person. In the reverse side, we have a negative with the A1 cells and a 1+ with the B cells, which on the face of this, the person is group B. But if you have a reaction less than 2+ in the reverse type, that is a discrepancy. If you have a reaction less than 4+ in the forward type, that's probably okay, but still not as acceptable. So the real problem is the weak reactions. What are some causes? Well, in the reverse type, the most common cause of having a weak reaction is there are not enough antibodies. And so what can cause this? It's a baby that has not made sufficient ABO antibodies yet. It's an elderly person who, as you get older, the amount of antibodies may decrease substantially to where you can get these weaker than normal reactions. What's a resolution? Let these tubes sit at room temperature for about 10 or 15 minutes and then respin them and reread them. What should happen is if it is due to weaker antibodies, by allowing more time for antigens to attach to red cells, then that should increase the strength of reaction. And so sure enough, when we incubated at room temperature, I got a 4+ with my anti-A, I got a 3+ with the B cells, so all is right with the world. Be sure to refer to your notes as you go through these problem sets because you're not at a point where you have all this stuff memorized. So please use your notes to assist you in coming up with answers. So we look at this patient, they're positive with anti-A, positive with anti-B, they are group AB. You say, but Terry, there's a 1+ with the anti-B. I know, but on face value, positive with anti-A, positive with anti-B, the interpretation is AB. Look at the reverse type, negative with A cells, positive with B cells, they are group A. So what's the problem? The weak reaction with the anti-B. What are causes? The only one that I can think of is acquired B. And so first thing, you'll want to get their diagnosis. Do they have colon or rectal cancer? Or do they have gram-negative sepsis? Do they have intestinal obstruction? And there's no resolution for this. There's no way to magically determine what their real true type is. So at this point in time in their history, if they need a transfusion, because we can't determine what their blood group is, we're going to give them group O cells and whatever their D type is. For plasma, AB plasma, although I would feel very comfortable giving this person A plasma because the problem is with the forward type. But that would be a decision made by you and your supervisor or you and your pathologist. So as always, let's interpret anti-A positive, anti-B negative, this person's group A. Reverse, positive A1 cells, positive B cells, the person's group O. So what is the problem? One of the problems is the 2+ reaction with anti-A. You should always get a 4+ reaction. In the reverse, we have a 1+ with our A1 cells. If you get less than 2+, then that's a problem that needs to be resolved. So what are some potential causes? We have a subgroup of A with anti-A1, or we could potentially have a patient with a weak reacting cold antibody that's directed against an antigen on the A1 cells. I would go for the subgroup, and how you would resolve it is test the patient cells with anti-A1, you would expect negative, and test the patient's serum with A2 cells, which you would expect to be negative. So this is interesting. We have a negative with anti-A, negative with anti-B, so our patient appears to be group O. In the reverse, we have a negative with our A cells, a positive with the B cells. They're typing as a group A. And the reaction with the B cells is very nice, it's 3+. So the problem is missing antigens. So what are the causes? Subgroups of A weaker than A2. Probably even weaker than AX or AL, but still, it's just a subgroup of A, weaker than A2, so the antigens are not showing up. So what's the resolution? Test them with anti-A, B. So we test the patient's cells with anti-A, B, because remember, it has 3 antibodies, anti-A, anti-B, and anti-A, B. And anti-A, B is thought to be the most potent of the 3 antibodies at causing agglutination. If the result was negative, then an adsorption or elution studies with anti-A could be performed, and these will help determine what A antigens are present. And that's something we will discuss later on. It's like, stay tuned for more. But if I threw everything out at you right now, which probably right now your head's spinning off your shoulders. But again, when we tested it with the anti-A, B, it was positive. So this is probably a subgroup of A, probably AX, which I wouldn't expect you to know the exact specificity. What I would want you to know, it's a subgroup of A weaker than A2. So forward type, negative with anti-A, positive with anti-B. This person appears to be group B. In the reverse, A1 cells positive, B cells negative, appears to be a B. So they match, but the anti-B, number 1, we have weaker than 4+. Number 2, we have mixed field agglutination. So what is the potential cause? Either this is a B3, a subgroup of B3, because those will always have mixed field agglutination when tested with anti-B typing sera, or we have a donor or a patient that was transfused with group O blood, and the patient's B cells are being agglutinated by the anti-B, whereas the group O cells are not. So when you shake that tube, you're going to get a sea of free cells followed by a tightly clumped group of cells. In this patient, we have positive anti-A, positive with anti-B. The patient appears to be AB. In the reverse type, the A cells are negative, the B cells are 1+, the patient is reverse typing as a group A. What's the problem? The 1+ reaction with the group B cells. What are some potential resolutions? This may be a patient who has a cold reacting antibody against an antigen on the B cells. So what we would do is run our screen cells, which the purpose of screen cells is to detect unexpected antibodies. An unexpected antibody is an antibody other than anti-A or anti-B. So anti-Lewis, anti-M, anti-N. There's several blood group antibodies that react at room temperature. And manufacturers do their best to make sure that your A and B cells are free of these antigens that could cause false. It's not a false positive, it's a real positive, but it will interfere in our ability to accurately determine a patient's blood group. So again, run a screen to determine if an unexpected antibody is present. Patient is negative with anti-A and anti-B, so they are group O. In the reverse type, they're negative with A1 and B cells, so they're AB. Whoa, that's kind of a problem, right? So what we're seeing here, what the problem is in the reverse type. They're missing expected ABO antibodies. And this could be caused by age. I've frequently seen very elderly people that their antibodies, it's not that the antibodies aren't there, that they're falling below the level of detectability. So what can we do to enhance detectability of ABO blood group antibodies is incubate them at room temperature. And so, let them sit for 10 or 15 minutes and then respin. And I guarantee you, as long as you can get them up to a 2+ reaction, that is valid for a reverse type. So that would be my call on this one. So this is the end of the Unit 6. So if you have questions, please write them down. Review your objectives. Listen to the presentation as many times as you need to. Read your textbook. Your textbook does a really good job. Spend quality time with all the case studies within the chapter and study questions. Your author has done a really good job, and it's to your benefit to spend quality time with those. The more times you apply your knowledge to these issues, the better your problem-solving skills will get. The only way to learn how to problem solve is understanding the why of what is happening and the specific tests to prove the cause of the discrepancy.